Assalamu alaikum. Good afternoon. Thank you very much, IPDI, for making a very academic platform. And we do really wait all the year along for these days to attend this academic bonanza. And I'm really grateful to be here among our teachers and the faculties from home and abroad and our senior junior colleagues to present my people over here. Thank you. This is Faizul Islam from National Institute of Cardiovascular Diseases, uh, presenting, as you know, by the time Dr. Mahaddin and Dr. Shakil Puri, they are all aortic surgeons. Prashant Dosar is there, all doing aortic surgeries. But NICVD, as you know, this is the National Institute, but we are not dealing that much of aortic cases. So when we find these patients usually come across, moving from all around the country, visiting so many physicians all over. They go to local physicians and they go to ENT specialists and then come to the cone to be diagnosed. So it's a matter of exclusion to diagnose. My case is a patient of 63 years. Is a hailing from Chandpur, farmer, and he has got the just developed change in voice for 3 months and with left-sided chest pain, and he was almost okay for the past 5 decades of his life, and and he was not living losing weight. He didn't have any significant other associated diseases, or didn't have any other diseases, but rather for this change of voice he attended his local physicians. They referred him to the ENT specialist, and they didn't find anything wrong in the ENT areas. So he was no history of diabetes or hypertension or no TB, no exposure of radiation, and no other gastrointestinal problem as well. And later on, they came to us, but he was a smoker. So we evaluated completely by physical examination. We collected all informations. This was, in fact, for we have got the all level of participants. So we are not detailed presentation is there. Is hemodynamically the patient was all okay, and the pulse was 92, pressure was not high, respiratory was not was okay, no respiratory distress was there, and we examined his oral and neck. There is no abnormality, and system examination also showed nothing wrong in the cardiorespiratory system, and the all okay, no murmur and nothing.
And now we listen from Dr. Mohammad
So
Ishtiaq
I'm
Saeed Al
just
Manzoor.
going across all these slides, and we collected all the informations. Later on, we are coming to
Everyone.
show what may be the diagnosis. So I
Respected
today, you know, as
persons,
Dr.
and
Mohideen
have
has
a
said,
series
how
of recognizing
aortic
congenital
lesion
arch anomalies. I
missed
work
at this age. We don't know whether he had any initial disease, because some days back we got a case of 43 years old age patient came with arterial luxuria with congenitally corrected TGA. So main presentation was dysphagia and was vomiting. So it's a matter of exclusion. So we didn't put to any provisional diagnosis. Rather, we put some differentials. We thought it may be retrosternal thyroid, chronic stable angina, because also presented with chest pain. We had the suspicion of, because we must have a suspicion, high index of suspicion, aortic aneurysm we kept, and laryngeal carcinoma. So everything we investigated. So chest was like this. So there was up, the medulla was there, widening was there. In the X-ray, ECG was almost normal, and echo showed there is little bit of inferior ischemia. And we did angiogram, because customarily we do all the patients we do coronary angiogram. We got a 40 to 50% lesion in the mid LAD, and we did CT angiogram, which showed there is a arch aneurysm, distal arch aneurysm, and this was the picture. And we evaluated the patient. We sat between ourselves. We did all the investigations so that we can, because the patient didn't have any comorbidities. It was okay, fine. So, and patient party was well explained. We sit between ourselves. We have got the next has got the vascular surgery department and cardiac surgery department. We all sit together. How can we move forward to offer the real remedy to the problem to this patient? So all investigation showed nothing wrong. So ultimately, we got this. There is a distal aortic arch aneurysm compressing the left recurrent radial nerve. That may be the cause, was the cause of his, and the cardiovascular cause of Ortner syndrome. As you know, once upon a time there's a systematic review of Ortner system was done in the by a Chinese hospital of considering 15 years of almost 25 years of cases. They searched for the other than the neck cases and other things, the cardiovascular cause of Ortner syndrome. So this is one of the finding of Ortner syndrome. So we planned that we will go for open surgery, excision of the aneurysmal sac and distal arch arthroplasty by using the Dacron patch and CABG because there was 50 to 60% lesion in the mid LAD. We plan for one graft to be given. If required, we will go into deep hypothermic circulatory arrest. So operative procedure we planned. We had we planned there's the extension of the Milton's incision toward the left thoracic cavity, and accordingly we planned that. And you see, we did the middle sternotomy. My nickname is Milton, so middle sternotomy was extended toward the left side. So we did sternotomy, but after doing the sternotomy, we found there is a dense adhesion of the pericardium, as well as the left thoracic cavity was not reachable to go for lima dissection. So another dilemma, we planned for, if required, we will put the lima into the LAD and we will do the aortic arch surgery. So we could not, but it took around 1 hour to free the heart. One of our teammates is there, Dr. Masud Jiaul Haq is there. So we took around 1.5 hours to mobilize the entire surface of the heart. And there was entire dense adhesion in the leg thoracic cavity. So another challenge came. So we extended, we divided, going to the left side through the second space. We divided the left internal memory artery rather. We couldn't dissect, rather we have to divide it to go into the left thoracic cavity and to approach to the left thoracic cavity. Interestingly, on table we found, but we couldn't apprehend before surgery that the patient had the bovine arch, but it helped the patient so that we put the aortic cannula just before the inguinal artery, but we get space so that we put another clamp just beyond the subclavian artery. So we didn't need to put any thought about the integrate cerebral perforation. So we maintained that, and we extended that. We did extensive mobilization and surgery, and the patient has so that was. But we had to go for the deep hypothermic circulatory arrest. We put it for about 35 minutes, and later on we put a second clamp just beyond the arch, the branches of the transverse arch, and we excised the aneurysm that was extended toward the thoracic cavity and also toward the left mediastinum. So there was huge debris inside it, and we removed all these things. And you see, this is there was a secular aneurysm, and we took all the tissues from inside, and we didn't need to excise the part. Rather, we trimmed all the unhealthy parts, and all the things all of the was sent for histopathology, and there was debris, and then distal arch arthroplasty we used the Dacron patch. Initially we put tube graft, but we didn't require that. So luckily, it turned into after all this work, it became easy. As you say, if your preparation is serious, then the surgery becomes easy. As that's why we call it, if you fail to prepare, you are failing to be prepared to be failed. So we did all workup, and the case turned to be rather easier surgically. So we did all these things. We used, the fibrin glue so that we don't, and LNT was found separated, so we couldn't put graft. That was another problem. And there are some video clips, more same thing. But interestingly, the patient was discharged on time after 12 days, and he came with a small surgical site infection. That helped us to evaluate the patient again, and we did the histopathology. By the time we got the histopathology report, it showed that it's a true aortic aneurysm, and all these things. This is the patient, and later on, we did CT angiogram. When the patient again came, we took swab. We treated the patient with the susceptible antibiotics, and patient got recovered. But we did the review CT angiogram that you see. Now there is no more aneurysm is there. It's well corrected, and the patient is now okay. And now thank you all from aorta. Thank you.
Thank you, Dr. Faizul Islam, for your brilliant presentation.